Amer, first of all, thanks for taking the time to come on Healthcare Unfiltered. I really appreciate, although I don't know, I don't see you wearing the Healthcare Unfiltered t-shirt. We have to talk about that. But let's start by introducing yourself to listeners. And I am also very curious, in part of your introduction, you have to tell us about your travel, because you travel, I live vicariously through you, through the pictures that you post. And one of the destinations that I want to go to, inspired by you, by the way, is the pictures you posted when you were at the Maldives. You posted these amazing pictures. I went crazy. So tell us about you. What got you into AML, MDS, and what got you into travel?
Yeah, thanks, Shadi, for invitation. This is a great broadcast, and I always look forward to all the different editions. I think you cover a variety of subjects, and it's always interesting to see what's going on. So I'm originally from Jordan. I came to the US in 2004. I'm currently an associate professor of medicine at Yale. I direct the hematology early therapeutics research as well as myeloid malignancy disease associated research team. I focus clinically on MDS and AML for both clinical work as well as research. In terms of traveling, I think this is something that I always enjoyed. I've been lucky enough to be able to visit more than 60 countries. And I think one of the nice things about academia is you get invited to different places and conferences internationally. Unfortunately, during COVID, that of course has been a problem for all of us. The Maldives actually is a place I always wanted to go. I wanted to go during in the past, but the opportunity never came through. And what happened actually after COVID, after we had the first year of COVID in which we could not travel anywhere, and I had a 10-day period in my schedule in which I thought, where can I go in a place where I cannot see anybody, so there is no chance I can get COVID. And then the Maldives made most sense because, as I'm sure you know, it's a country of many islands, and each island has only one hotel. It's like very small islands, and very minimal number of tourists on each island. So it was a perfect setting. But I think the views, the nature, scenery is among the most amazing I've been.
Wow, you've been to over 60 countries.
Yeah, and I think it's I think we are living in a world where traveling is much easier. It's amazing actually. Some of the invitation I've gotten, I had the opportunity to speak in Bali, for example, in the American Society
Wow.
of Hematology highlights after ASH 2018. And after that, I was invited to Sri Lanka, actually, by the by the Sri Lankan Society of Hematology. So I went there. I gave some talks. It's amazing. Like I had the chance. Also, I was invited to China. So I think it's something where you can mix some of the academic work that you do with some traveling. And luckily, we are able to do a lot of our work remotely, as I'm sure in
Yeah.
terms of
Yeah.
research.
Amer, what got you into myeloid malignancies and hematologic malignancies? Was it something during residency, fellowship? What got you into that field?
Actually, it was during medical school. Since I was little, I knew I wanted to go into medical school. I'm sure you are from the same area, and since you are little, they instill into this that you should become a doctor. So I grew up kind of thinking that I want to be a physician, but I wasn't sure on the specialty until medical school. Um, as a fourth year medical school, one of my first rotations was actually in hematology oncology, and we had a little kid. He was like 8 years old with advanced Ewing sarcoma, and he was mostly in the hospital for palliative care because he has not responded to any treatment, which were very limited. And in Jordan, we have very good clinical care, but we don't have clinical trials. So it was like frustrating not to be able to offer the patient any treatment and just work on their symptoms. And that kind of got me interested both in doing more on hematologic malignancy, myeloid malignancy, AML, MDS, but also in terms of doing clinical trials. And that's what made me come to the US.
That's wonderful. So we're going to talk about MDS and AML. I have to tell you, so I mean, I'm older than you. I'm not going to give my age, but I'm going to tell you that when I was in residency and fellowship, MDS as a disease of myelodysplasia, which I'm going to ask you to simplify for listeners, was really viewed as it's a disease of older people. Some people, most people need no treatment, and some of them develop leukemia after a while. This is simple terms. And then as things progressed, it almost became its own entity as a disease, judging how ASH views these diseases. So let's start by, when we say MDS or myelodysplasia, what is that? How do you define that entity?
Yeah, that's actually a very good question, because I think MDS is somewhat difficult to conceptualize even for some physicians who don't do the disease on ongoing basis. I think it's interesting because it has a full spectrum. With MDS, you have some patients where you do nothing except observation of the patient every 3 months with routine blood counts, and you don't intervene, all the way to recommending allogenic bone marrow transplantation from the first visit you are seeing the patient. So it's a very um, large spectrum, both in terms of the biology, the clinical course, as well as the treatment recommendations. And now we are starting to understand more how the biology and the molecular genetics connect to the clinical course of the disease. But usually there are certain features that exist along the entire spectrum of MDS, which are bone marrow failure. So it's a form of bone marrow failure, meaning that the bone marrow is not functioning well, so it's not making blood counts. You have neutropenia, thrombocytopenia, anemia, and those complications, as well as some degree of progression to acute myeloid leukemia. So around 1/3 of patients with MDS will progress to AML at one point. Ineffective hematopoiesis is a result of abnormal maturation, dysmaturation within the bone marrow, and that's what leads to the cytopenias. Uh, Patients with MDS, I think, as you mentioned during your introduction, they tend to be older. So the general age or the median age is in the mid 70s. So I think this is another aspect that makes it more challenging compared to other diseases, because when your average patient is 74, 75, that limits a lot of some of the aggressive interventions that you recommend in some patients.
So do we know what causes myelodysplasia? I mean, I obviously realize it's a disease happens in older folks, but frankly, most cancers happen in older folks, whether heme malignancies or solid tumors. Do we have an etiology for myelodysplasia?
Yeah, so most patients, as we do with, I guess, with many other cancers, what we call de novo or idiopathic, because we don't know more than 80% of the time, and around 10 to 20% of the time, it's secondary or therapy related, meaning that it results from a previous chemo or radiotherapy exposure due to another cancer. That's an entity defined as therapy-related myeloid neoplasia by the WHO. The incidence of this is actually increasing because the survivorship after cancer in general is increasing, and we have many patients who live many years now after breast cancer or prostate cancer, where they receive some kind of treatment. Then you have secondary forms of MDS that are not therapy related. So those patients would be a minority of patients who had Down syndrome or some other congenital conditions, genetic predisposition. But for the most patients, we usually say it's somewhat really hand waving interaction between genetic predisposition and environmental factors, which are really difficult to define, because in most families you end up only with one person who has MDS, and so it's not clear why this particular person and not the siblings, or got that type of disease. I do think that the biology now is being explored better. There is this entity, clonal hematopoiesis of indeterminate potential, CHIP, which has been defined as certain alterations, somatic alterations in the genes that are common in myeloid malignancies, that occur in patients with normal blood counts, not patients actually, I should say people, because it happens in almost 10% or higher among people who are older than 60 years old. So it's quite a common phenomena, and we are realizing that many of those patients are at higher risk of developing myeloid neoplasms. However, most of them do not develop it. So even within this group of people, we still don't fully know what are the reasons why some people develop myeloid neoplasms and why people don't.
So you mentioned something about myelodysplasia, which is this bone marrow failure. So basically there are some inability of the bone marrow to produce the cells that it normally does. Why does it happen that sometimes the bone marrow cannot produce anything, like no platelets, no white cells, no red cells, but some other times only the red cells they can produce, but you still have normal white cells, normal platelets, and both of them are still myelodysplasia. So there's more of a, this ineffective ability to produce the cells is not always all types of cells, like could be one or another.
Correct. Yeah. So it happens on a spectrum. So anemia, ineffective erythropoiesis, is the most common feature of MDS. So that's more than 80 to 90% of patients with MDS will have anemia. Now, especially in more advanced forms of MDS, usually you have some degrees of thrombocytopenia or neutropenia as well. Some patients will have isolated thrombocytopenia or neutropenia. That's not common. I would say that's probably less than 10% of patients. But you're right, the spectrum varies. There has been new studies showing associations between certain genotypes and certain phenotypes in terms of the blood counts and blast count. But I think the bottom line is that the presentation is so variable that it's very difficult to put every patient in a box. I think that ineffective erythropoiesis is a dominant feature in all versions of MDS. So it's not common to see someone with isolated thrombocytopenia or neutropenia, but for the most part, ineffective erythropoiesis is something you often see.
Do you still call myelodysplasia as pre-leukemia, or do you view myelodysplasia as a completely separate disease and leukemia as a different disease?
Yeah, we think of it more as a spectrum. I don't like the term pre-leukemia because I think it tends to sometimes make not only the patients but also the physicians underestimate the severity of MDS, because we'll probably talk about this later, but the most common reason for death among patients with MDS is not progression to acute myeloid leukemia. Most patients with MDS die from complications of the cytopenias, of the bone marrow failure, rather than progression to acute myeloid leukemia. So when you talk about pre-leukemia, many patients are so focused on not developing acute leukemia. However, we try to emphasize to them that when your blood counts are quite low, this can be as problematic and as life-threatening as someone with acute myeloid leukemia. In fact, when you have excess blasts, especially close to the range of 20%, so currently the WHO defines that if you have 20% or more blasts in the bone marrow, that's acute myeloid leukemia, while if you have less than 20%, that's within the MDS spectrum. And of course, that's an arbitrary cut point. Many times you don't think that someone who has 18% blast versus 21, 22% blast will have different biological behavior in terms of the clinical course. And we often actually treat the patients similarly many times. However, we do understand that myelodysplasia has a full spectrum. I do tell patients it's a cancer from the get-go, because I get to see patients who have never heard the word cancer before, and they've had MDS for years and nobody told them that this is a cancer. They tell them it's a syndrome, it's an anemia, it's a pre-leukemia. So I think it's important for them to understand, because it can affect their perception of the need of monitoring, going on trials, management when it's needed.
That's a good point. So let's let's step back a little bit. So you have a patient that comes into your office and you diagnose myelodysplasia. What tests are you going to do to decide on management? Because honestly, Amer, when I was in residency, you'll have to guess basically how long ago this was. The treatment of myelodysplasia was erythropoietin injections. That's really it. And GCSF and GCSF. So actually, there was a paper was in Blood was combining GCSF and Epigen. That was really the treatment of MDS. That's how long ago you have. So you have this patient comes in, you diagnose MDS. Take me through your thought process of how you're going to evaluate this to reach a decision of what to do, whether it is doing nothing or doing something.
Yeah, and by the way, like ESAs continue to be the mainstay of treatment of most patients with MDS. But of course, since then we had several new treatments that have evolved, and it's a very active field. In terms of like the first visit in the clinic, my first mission usually is to confirm the diagnosis of MDS. As a tertiary center, many of the patients come to us for a second opinion or sometimes third or fourth opinion. So the patient has been already diagnosed somewhere with MDS. However, you need a very good hematopathologist because sometimes it can be tricky to diagnose MDS, and there are actually several trials that show discrepancy between different pathologists in defining MDS. So we always ask for the slides to be sent, or sometimes we do a new bone marrow for the patient to confirm. The second thing is you also have to exclude other things that can look like MDS to the pathologist. So the MDS can see dysplasia, and this is why I actually generally don't like the term also myelodysplasia, because myelodysplasia can result from many things. Myelodysplasia means that you have abnormal maturation within the bone marrow, and that can result from many things, including drugs, including B12, folate deficiency, certain rare metal deficiencies, copper deficiency, LGL. So there are different things that can look like MDS, but they are just dysplasia. So myelodysplastic syndromes refers to the condition, to the cancer that is associated with dysplastic changes in the bone marrow. So I usually send all of these tests, especially copper deficiency. I had patients and B12 deficiency. I had patients who were diagnosed elsewhere with MDS, and they turned out to have B12 and folate deficiency or copper deficiency. So it's very important, especially if you are thinking of treatments beyond DSA, to make sure you are not dealing with something else. Once you have made the diagnosis, your next stop will be at trying to risk stratify or prognosticate for the patient. Because as I mentioned, it's unusual in the sense that the treatment varies all the way from observation all the way to recommending bone marrow transplant. And the way we do it right now is we look at the bone marrow blasts, how many blasts does the patient have? We look at the blood counts, and we look at the
how do you do, don't digress, but I'm curious, how do you do? And by the way, for listeners, I may know the answers to these questions, but I probe my guests because I serve as a reporter for you. But when you say you count the blast, I mean, this is very subjective, right? I mean, the hematopathologists are going to look under the microscope and say, 20%, 15%. How does that work?
No, that actually has not changed much as well since your days of doing MDS. It's still a pathologist looking under the microscope, and usually the recommendation is that you have a very good aspirate of the bone marrow, specular, good quality aspirate, and then usually they would count 200 cells in the aspirate, and then they will give you a percentage of those, how many of them are blasts. You are right that one of the problems we have in MDS, as I mentioned, studies have shown some variability between the same bone marrow biopsy being seen by different pathologists in terms of their diagnosis of MDS, but also in terms of how many blasts do you have. So some might call 5%, some might call 8%, and I think in general this can be an issue more on a clinical trial enrollment. For example, when you have like an 18% blast in the bone marrow versus 21% blast, it might not biologically be that different. There is definitely an overlap, but technically, if you are less than 20%, that's MDS, so you cannot go on an AML trial for an older patient, and the other way around if you are more than 20%. So some of these cutoffs are interesting from a classification point of view, but they don't necessarily always affect how you treat the patient.
Okay, so that's the first thing you said. You'll check on the number of blasts. What else do you do?
Yeah, so we look at the karyotype, see what is the cytogenetics, because those have been shown to be the most important or one of the most important predictors of outcomes of patients, survival, as well as progression to acute myeloid leukemia. So you need to send for metaphase cytogenetics as well as FISH, fluorescent in situ hybridization. We do these tests routinely, and we also look at the blood counts. And you mix all of these together using different classification schema tools. Some of them also add the age, or they add transfusion dependency, etc. And then you come with different scores. Now, the most common used ones is the revised IPSS, or International Prognostic Scoring System, or as well as the WHO-based prognostic system. However, there are more than 20 of these different systems. At the end of the day, what you come to is putting the patient in one of two big groups, either what we call lower risk MDS or higher risk MDS. And those are big differences in the management. So trying to put the patient in the right group is very important.
So who's the lower risk and who's the highest risk?
Yeah, so depending on which schema you are using, for example, in the revised IPSS, you have two risk groups, very low and low. Those are considered lower risk. And then you have an high and very high, and those are considered high risk. And then you end up with the intermediate risk group. So this intermediate risk group, there are different ways in which you can classify these patients. Ultimately, this is important because with lower risk disease, the goals of treatment are different than the high risk. In the lower risk disease, your goal of treatment is quality of life, is to reduce the complications from cytopenias, to try to keep the patient outpatient by minimizing infection, bleeding, minimizing complications of anemia. However, currently, we don't have treatments that can prolong survival or change the natural history of the disease for lower risk patients. In higher risk disease, on the other hand, the survival is generally very limited, can be less than a year basically for untreated disease, as bad as acute myeloid leukemia. So in those patients, the goal is to change the natural history of the disease. Generally, that happens by getting the patient to a bone marrow transplant if the patient is a candidate for bone marrow transplant. And of course, because the patients on average are in their 70s, many of those patients are not. So we often treat them with hypomethylating agent-based approaches. So those are the most common treatments for high-risk MDS: azacitidine, decitabine, and most recently, the oral version of decitabine, what we call CDEC, cidazoridine with decitabine. This is an oral version that was approved in 2020 for high-risk MDS.
And we'll get into that. Before we do that, when we talk about, I still want to hone in a little bit on this low risk and high risk. I know that there are so many of these classifications based on all of these factors that you mentioned, right? The age, the blast count, all of these things. But tell me about the chromosomes, specifically the karyotype. Are there specific chromosomal abnormalities that automatically will put you high risk category by itself?
By itself, it's not, because you have to reach 1.5. Basically, to be in the higher risk, you have to be more than 4.5 points. So depending on the cytogenetic abnormality, they can get you close to it. But if your counts are absolutely normal and your blasts are low, they might not be enough by themselves. However, many times these things tend to go hand in hand, meaning that if you have complex or bad karyotype, for example, complex karyotype, it tend usually go hand in hand with low blood counts. So it's not that you often have discrepant, like, very bad karyotype, but you have normal counts. But yeah, it's a constellation of all of these factors.
So what I heard you say, and we're going to go through this in a little bit. So the low risk, oftentimes you may do nothing, because in the high risk, you definitely want to do something. And then the intermediate risk is, we'll go over that because it's probably could go either way. But let's talk about the low risk a little bit. Are there low risk patients that you would treat?
Yeah, so it depends on their blood counts, because technically you could be a lower risk MDS patients. Your blood counts, let's say you have mild anemia. So if your hemoglobin, let's say, is 10, 11, you might not be symptomatic from it. So you're probably not going to do much in this patient. You are just going to have the patient come every few months for blood counts. However, as the blood counts worsen, if the patient is symptomatic from anemia or they start needing transfusions, you often want to intervene on that patient. So, and we'll talk about the treatments, but
yeah. So what do you do for low risk patient that gets the counts worse?
Yeah, so if the main issue is anemia, the main option usually is erythropoiesis stimulating agents. So usually you use these drugs in patients who are most likely to respond are the ones who don't need frequent blood transfusions and the ones who have low erythropoietin levels. So we usually check the EPO level. In patients who have high EPO level or have frequent transfusions, they are not likely to respond to ESAs. So in those patients, you have a number of options. One of them is to try ESA with GCSF, as you mentioned. Another option is off-label use of lenalidomide. So lenalidomide is approved for deletion 5q MDS. So if you have deletion 5q, lower risk MDS, those patients have almost 65% chance of transfusion independence with lenalidomide. So that's one option. However, even if you don't have deletion 5q, around 1/4 of patients with MDS would respond to lenalidomide. So we would consider it in someone who is not responding to erythropoiesis stimulating agents or less likely to respond because their EPO level is quite high. A new drug that has been approved also in 2020 is luspatercept. So this is a transforming growth factor beta ligand. What does it do is basically it looks or it traps. It's an antigen or it's a protein trap. It traps these ligands from activating the transforming growth factor pathway. This pathway leads to ineffective erythropoiesis. So by disrupting it, you are improving the erythropoiesis and leading to improvement in the anemia. It was shown to actually work the best in patients who have ring sideroblast. This is a form of abnormality in MDS where patients have accumulation of iron in the mitochondria around the nucleus in the shape of a ring. So we call it ring sideroblast. Those patients with lower risk MDS and ring sideroblast, which, by the way, is associated with a specific molecular alteration called SF3B1. This happens in most of these patients. They have a response rate of around 38% of transfusion independence with luspatercept. So those are the main options. Other options also that are available for some patients with lower risk MDS includes the use of hypomethylating agents, which we typically use for higher risk, but we can do it in lower risk patients who are not responding to other treatments. But also we consider immunosuppressive therapy with ATG and cyclosporin in some patients as well.
Interesting. Amer, tell me, how do you utilize iron infusions in patients with MDS when you are going to use the erythropoietin and red cell growth factors? I ask this because it's a common confusing issue for students, fellows, and even general practitioners.
Yeah, so I'm not sure if you meant iron chelation. So in general, we don't tend to give iron to patients with MDS because they are often having an increased iron absorption because of their anemia, and often they are transfused, so they actually have high iron levels. We actually tend to run into the issue of iron accumulation in them, and many times for patients with MDS, we are using iron chelation therapy, especially in lower risk patients, because buildup of the iron can cause on the long run can cause problems with the liver, with the pancreas. So iron chelation is actually one of the somewhat controversial subjects in MDS because we did not have studies that showed improved survival with iron chelation therapy. But we have a lot of retrospective data as well as a recently conducted randomized clinical trial which showed event-free survival to be better with chelation called the Tellisto trial. The problem with chelation, yeah, go ahead.
I was going to say, but I mean, because you run into the problem of iron overload when you're giving a blood transfusion, right? I mean, if you, but there are many patients who have low risk MDS that may have not required a lot of transfusion to have iron overload, and you're giving them growth factors. For these patients, you just give them the growth factors, and I don't know, how long do you wait before you say, I tried and it's not working? Like, is there an actual cutoff?
Yeah, so usually we try the erythropoiesis stimulating agents for 8 to 12 weeks. So if it did not do anything by 12 weeks, it's not likely that it's going to improve the transfusion needs. I have to say that one of the issues I see in the community is that the ESAs are not being dosed at the right dose because ESAs, as you know, they use it also for patients who have anemia from kidney failure. And in that setting, the ESA dose is much lower. So the ESA dose should be, if you are using erythropoietin, for example, you want to use 60 to 80,000 units, international units each week for a good duration. RNS, we want to use 500 every 2 to 3 weeks before you say that the ESA is not working. Sometimes we get patients who are getting much smaller doses. So I make sure that the dose is optimized and the patient has already received 8 to 12 weeks before you move on and say the drug is not working.
And when you say the drug works in patients who require transfusion, they become transfusion independent. And those that probably don't require transfusion, you probably wouldn't, I mean, just like increasing the hemoglobin by 1, 2, like, is there, I guess, what are the definition when you say it's not working?
Correct. So the standard definition or the best response you want to get to is transfusion independence. Transfusion independence means that you're not needing transfusion, and that's usually measured in 8-week period. So if you have 8 weeks without transfusions, that's transfusion independence. However, some patients you get defined responses, the international working group criteria responses, which define them as increasing the hemoglobin of 1.5 above the baseline and transfused, or a reduction of 50% or more in your hemoglobin needs, basically. So if you were getting, let's say you were getting 8 units or 10 units every 2 months, you are down to 2 to 4 units. So you might not be transfusion independent, but your transfusion needs have significantly reduced. Sometimes in the community, this is another issue that we see sometimes in the community, is that the patient continues to need transfusions, and actually the transfusion amount has not improved. Like, the patient baseline was 6 to 8 units, and they are still getting 6 to 8 units every 2 months, but they are kept on the ESA for 1 or 2 years. And the reason is because the patient says, I feel better, but generally that's not a good reason to keep the
Yeah.
patient on a treatment that has not really changed their transfusion needs.
So then the high risk, you mentioned the kind of buffet of treatments. And I think the ones that confuses people, I would presume, is, I mean, it's a huge difference between bone marrow transplant, which we know not everybody can get because you need to have a donor, although obviously you can have a matched unrelated donor. But, and then you have the chemotherapy and so on. So how do you, let's say a 55-year-old individual who obviously can get both, how do you determine whether this is somebody you're going to proceed with transplant with its own complications that I'm sure many of our listeners are aware of, from graft versus host disease and others, versus the hypomethylating agents and other type of chemotherapy?
Yeah, that's a good question. And actually, these two treatments are not mutually exclusive. So many times we end up doing the hypomethylating agents as a bridge to transplant rather than instead of transplant. So your first step is always like determining whether the patient is a transplant candidate. And there has been a lot of improvements in transplant eligibility over the years. On the theme of, like, I think some of the misconceptions that I see in the community is many patients not coming to us despite having high risk MDS and being initiated on hypomethylating agent treatment by their doctors. And let's say the patient is 68 because their primary oncologist thought that 68 was too old for transplant. However, we actually routinely, and many centers routinely, would transplant patients who otherwise in good performance status up to the mid 70s, 75. And recently, we actually have randomized studies transplant studies are very difficult to do in a randomized fashion. So typically how we do it is what we call biological assignment studies, meaning that if the patient has a matched donor, they would get randomized to transplant. If they don't, they get randomized to continuing the HMA. We have two studies, one from Europe and one from the US, that showed up to the age of 75 that going to bone marrow transplant actually improves the 3-year survival of those patients. So I encourage everybody, like, even if the patient is in their late 60s or early 70s, have them see at least a transplanter or an expert to consider whether transplant is something that they can have.
What's the data on transplant? If we take 100 patients who are on with MDS, just, hodgepodge of MDS, 100 patients, what are the expectations for these transplanted 100 patients in terms of mortality, transplant related, non-transplant related, GVH? What do you tell your patients when they get transplant? Because I tell you, I never want to get an allogeneic transplant. I feel it's a horrific type of and I've covered a lot of transplant patients.
Yeah, I imagine. I think transplant, in terms of supportive care, in terms of using high resolution matching, so getting better matching for patients whether related or unrelated, as well as antibiotics and other forms of support, have all improved, which has significantly reduced the transplant related mortality compared to 10, 20 years ago. So it's definitely still a risky procedure, but I think the risk has gone down to a degree where it's allowing us to transplant people who are in their 70s, as I was saying earlier. So I do think the risk of dying from the transplant and the risk of the disease both are linked to the baseline of the patient in terms of their age, in terms of their comorbidities, in terms of their biology of the disease, the risk group of the MDS. But if you lump all the patients together, we generally estimate around a 40% chance of long-term survival with transplant. Again, that's as a big group. And of those, we estimate the risk of relapse around 40%. So most patients with MDS actually who undergo bone marrow transplant, if they die, they don't die from the transplant itself. Most of the time, if they die from the relapse of MDS and the complications that come afterward. The transplant-related mortality, again, varies, but it could be all the way from 10 to 25%, depending on the risk, the factors that we discussed in terms of the patient risks as well as the disease risks.
What's hot and up and coming in MDS? What are you were at ASH several weeks back and so on. What struck you as really interesting in MDS, and recognizing that you can't really sum it all, but what's really stood out for you?
I think what stood out actually is the amount of research that's going on. So MDS, I think, as you mentioned, for many years, we really did not have new treatments. Those hypomethylating agents we discussed, azacitidine and decitabine, were approved in the years 2004 and 2006. So for 15 years, we did not have any single drug get approved, which amazing when you think about solid oncology or even leukemia and AML, where we had 8-9 drugs approved since 2017. So MDS has always lagged behind in terms of the clinical research. But this has changed in the last 5 years, where the interest has peaked as I think new and interesting agents are being tested both in lower risk and high risk MDS. So right now, for example, we have at least six large randomized studies of high risk MDS that are ongoing, which again is unprecedented in MDS to have all these randomized studies going at the same time. I think what has been somewhat disappointing is that two of those studies have released press releases. We still don't see the data of the randomized phase 3 showing that they did not achieve the primary endpoint, despite having encouraging phase 2 data, single arm or randomized phase 2 data. One of those, the Panther study, which used a drug called Pibonidastad. So Pibonidastad is a NID8 activating enzyme inhibitor. This is a pathway that's upstream of the proteasome. So this drug inhibits this enzyme. And in early phase trials, this has been shown to increase the CR rate from 20% to 50% in a randomized phase 2 trial, as well as triple the duration of response from 12 months to 36 months. So there was a lot of excitement about this drug. However, the Panther study was just released, and it was actually presented in ASH this year, where there was no difference between the azacitidine monotherapy versus azacitidine with Pibonidastad. The CR rate on that trial was close to 30% between the drug and the combination and the monotherapy. So this was, I think, somewhat disappointing, but one of the main findings of this ASH. Another drug called EPR246. This is an agent that works on TP53. TP53, as the audience knows, is associated with many cancers, more than 50% of cancers. But in MDS, like in other cancers, having TP53 mutations is very bad. It tends to confer high chance of death even after bone marrow transplant. Less than 20% of those patients would be alive long term after transplant if they have TP53. So this drug has also shown early phase 1, phase 2 data in patients who have TP53. And by the way, it works by correction of the misfolding of the TP53 so that it's functional again. The response rate also was 40 to 50% CR rate. However, the phase 3 of that drug also was press released that there was no advantage in the, or there was some advantage in the complete response rate with the combination over monotherapy, but it did not meet the threshold that was defined for the primary endpoint. So essentially, it's a negative study for the primary.
Which is interesting, because I do think, one of the things that we hear a lot of chatter about in trial design is, yes, remission is great, obviously, right? I mean, we all want to get remission, but on and on again, we have studies where we do not see the correlation between remission and survival. So you get the remission, but it just doesn't last, where you really have this improvement in outcomes. So I think it's always a lesson learned to figure out what we need to do. So you mentioned earlier, Amer, that 1/3, when you talk to your patient with MDS, 1/3 of these patients transform to acute leukemia, while 2/3 actually don't, which is really important. I bet you there are people who are listening to this who did not know this statistic, because it is important. So whenever you have this patient that transforms from MDS to acute myeloid leukemia, how do you handle the leukemia in that patient? How do you evaluate? And maybe that's a good segue to talk about acute leukemia in general, acute myeloid leukemia, in terms of assessing the patient that comes in the door and deciding maybe the risk stratification and so on. So you have this AML patient comes in the door. What are you going to do?
Yeah, again, I think that's a very interesting subject, because patients who have MDS that evolves to acute myeloid leukemia unfortunately tend to be the ones who are the most challenging to treat, especially if they have already received hypomethylating agents. So if they have received HMA, azacitidine, and decitabine, and they progressed after that to AML, those patients tend to do generally very poorly. How do you work with them depends on the particular goal of the treatment. So if the patient is a transplant candidate, sometimes you would consider intensive chemotherapy. And speaking of ASH updates, we had updates on a drug called Vyxeos, CPX351, or liposomal cytarabine with daunorubicin. So this drug was shown to improve survival in therapy-related AML and secondary AML among older patients who are candidates for intensive chemotherapy. 2 presentations from ASH this year from the US and French groups looked at the use of CPX351 in patients with higher risk MDS, and found that you are able to get around 50% of those patients, depending on the response criteria you are using, to respond and to go to, many of them went to bone marrow transplant. So it's clearly a highly selected patients who are able to go to bone marrow transplant, but it seems the drug certainly has some efficacy. It would be interesting to see if a randomized study will be done to compare it to hypomethylating agents, which many of us think is a good trial to do. The other approach you could do, especially if the patient is not a candidate for bone marrow transplant, is based on data that I actually presented on behalf of co-authors, and you adding the venetoclax, which is a BCL2 inhibitor. It's an oral a drug that's given to patients daily, and in MDS compared to AML, it's given for 14 days only. So in trials both in the frontline and the relapse setting, adding it to azacitidine, it has showed decent activity. So in situations where I cannot get the patient to a clinical trial, which is of course the preferred treatment after HMA failure, I try to add venetoclax sometimes. And again, this is not FDA approved, it's just investigational. But since venetoclax is already on the market, one of the things we can offer the patient is trying to add venetoclax. It's myelosuppressive, so the blood counts will be low, and you have to manage the patient carefully. You have to do bone marrow after cycle 1 to make sure you hold the drug if there's excessive myelosuppression. And you have to be careful about the drug interactions, because this drug interacts with a lot of other drugs, CYP inhibitors, for example, antifungals, and you have to adjust the dose. So there are many things that are, I think, important to kind of know about this if you are going to use it outside the context of a clinical trial.
And you're talking about basically specifically treatment, acute myeloid leukemia that evolved from myelodysplasia.
Or MDS that basically progressed on HMA, because sometimes what happens is that your MDS progresses after the HMA. So meaning the blast count might go from 8% to 15% on the azacitidine. So it's still not AML, but this is MDS. In therapy-related AML, using venetoclax with hypomethylating agent or CPX, those would be on label. This is FDA indication.
You can always get a hematopathologist, take them to lunch, say, we're going to go back to the microscope. We'll do 20%. I can get the venetoclax. Okay, this is off the record, you guys. So let's then talk about acute myeloid leukemia de novo, which is this disease that did not come in from MDS, and so on. So what's the difference really between acute myeloid leukemia and MDS? Just the percent of blast count? I mean, is there anything different, or is it biological differences, like, in terms of how the disease evolves?
No, certainly there are a lot of biological differences, but similar to MDS, the biology of AML is also highly variable. You go all the way from APL, which a completely different animal, acute promyelocytic leukemia, in terms of how it presents, currently how it's treated, and a very high survival rate with ATRA and arsenic that approaches 85-90% these days for lower risk patients who are treated in the big centers or with the right approach, all the way to AML with very complex cytogenetics, especially TP53 mutations, where those patients have a survival of only 10%. So again, a big spectrum. However, patients with AML generally tend to be somewhat sicker overall when you compare them to MDS patients, because their blood counts generally tend to be lower. AML is slightly younger in the median age of incidence. So the median age at presentation is like 68 compared to early 70s in patients with MDS. However, we tend to see many patients with AML who are younger patients. So as someone who's a leukemia attending, this is what brings me in the middle of the night when there's a patient with acute leukemia, because those patients could get very sick and die within hours or days of presentation if they are not managed correctly, especially if they have a very high white cell count, or they have symptoms of leukostasis, when those blast cells obstruct the capillaries in the brain or in the lung.
Mm-hmm. So when you're faced with this acute myeloid leukemia, though, risk stratification? What are the mutations you look at, the chromosomes you look at to decide? Because is there high risk, low risk, intermediate and acute myeloid leukemia similar to MDS?
Yeah, so they are different schema, but the most common used ones, the NCCN or the ELN, European Leukemia Network classifications, use 3 different groups, basically poor risk or high risk, intermediate, and low risk. And people call it also favorable risk for low risk. I've never been a fan of favorable risk because even in favorable risk, the survival is close to 50-60% long-term survival. And when you tell the patient this is favorable risk and they tell you there's a 40% chance I'm gonna die in the next 5 years, and you call this favorable risk, so it's somewhat relative to the more aggressive forms. But the way we decide on these are actually linked mostly to the genetics in terms of the karyotype as well as the molecular features. So compared to MDS, where we look also at the blood counts and the blast percentage, in AML, those two are not involved. So the main 2 things we look at for AML are the karyotype, the genetic abnormalities, as well as the presence of certain genetic alterations such as core binding factor leukemia, the presence of certain genetic recurrent alterations.
So, talk to me a little about we see a lot about FLT3 and NPM and all of that. How do you do those all the time? Like, how do you factor these in some of your risk stratification? We're going to talk about therapy, but in risk stratification.
Yeah, so those are actually pretty standard now. They should be done, and they are really available, I think, in most centers. So those are the abnormal that you should always get in any patients with AML in the workup is karyotype, the conventional cytogenetics, the fluorescent in situ hybridization, and then you get the FLT3. So FLT3 is a genetic alteration that happens in close to 1/3 of patients. So it's common. It's classified in 2 big groups: FLT3 ITD, internal tandem duplication, which is 3/4 of those 35% of patients. And then you have TKD, which happens in 1/4. This tends to confer a negative prognostic impact. We often tend to recommend transplantation for those patients. But beyond the prognostic impact, we have drugs that inhibit them. So compared to MDS, we were just talking about earlier, in AML, we are actually having more and more targeted therapies, meaning that you go after certain alterations. So you apply the concept of precision medicine or individualized medicine more commonly in AML compared to MDS. In addition to FLT3, we look at Mpm1. So this is also common. Around 40% of patients will have Mpm1 mutation. In contrast to FLT3, Mpm1 is actually a good mutation to have. So having that mutation tends to improve prognosis. You have the mutation called CEPPA. So having 2 mutations of this or double mutation is also associated with good prognosis. And then there's a bunch of other mutations that we recommend getting in the guidelines, such as IDH mutations. 20% of patients will have an IDH mutation, which also have targeted therapies. There are other ones such as RUNX1, ACXL1, TP53. Those don't have approved targeted therapies, but they tend to worsen the prognosis of patients. So those molecular alterations are important not only for prognosis, but also to guide the treatment.
So when I was in training as a resident and even as my first years of fellowship, the treatment of AML was 7 days of cytarabine, continuous infusion, and 3 days of anthracyclines. And I'm going to tell you that the most important question that has been like tens of papers on and so much debates on podiums and so forth, were 2 questions. You may laugh at this today, but there were 2 questions. One is, do we use low-dose daunorubicin or high-dose daunorubicin? And the second question was, do we use daunorubicin or idarubicin? And I can't tell you, I'm sure you know, but I can't tell you how many debates I've listened to. that was the hottest thing in AML at the time. So tell me where we are now. I mean, I presume we are not now at 7-3 anymore. We probably resolved, hopefully, the question of dose and which intracycline. Or are we still where we were 20 years ago?
No, I'm glad we moved away from these discussions, but you are right. For a long time, unfortunately, and you would be like surprised how many thousands and thousands of patients went on trials to look at different doses of daunorubicin, and as you were saying, and I think again those are important questions, but probably were more important back in the day when we did not have anything that improved survival beyond 7+3. So 7+3 actually has been described in the early 70s. 1973 was one of the first papers about it, and it's kind of funny because it's connected to 7+3. But for almost 40 years, and I don't think this is precedented in any cancer where you have like been using the same treatment for 40 years until the year 2017. So it's not, when you graduated from fellowship, it's probably many people who graduated even 2015 or stopped doing leukemia work. Some ways similar to how I feel with multiple myeloma. Like, after I left the fellowship, tons of new drugs have come into this space, and it has been very difficult to keep up with. Since 2017 in AML, we had 9 drugs approved for AML beyond 7+3. So it's an incredible number of new developments. However, 7+3 still remains the mainstay of treatment of many patients, but we have a little bit of variations that we apply to it. For example, if you have a FLT3 mutation, we add a FLT3 inhibitor. The current standard is midostaurin. This is a FLT3 inhibitor that was shown in the ratified trial to improve survival in patients who have FLT3 mutations. So 7+3 with midostaurin. However, there's a large number of other FLT3 inhibitors that are being tested right now in clinical trials. So there actually was a recent press release of another FLT3 inhibitor in the frontline setting called quizartinib that was shown to improve survival also in combination with 7+3, but compared to placebo. So 7+3 with quizartinib versus 7+3. And there are another one called gilteritinib that's approved in the refractory relapse setting. Also, we talked about Vyxeos, or the liposomal vincristine the liposomal cytarabine with daunorubicin. And the idea here is that when you are doing a fixed molar ratio between the two drugs in those nanoparticles, they seem to be delivered to the bone marrow environment more selectively. So there's less toxicity with this drug. Anecdotally, actually, it doesn't cause hair loss, which many patients, you'd be surprised, are very happy about. But it seems to also has less cardiotoxicity. And it has been shown to improve survival over 7+3 in patients with acute myeloid leukemia with therapy-related AML. You also have IDH inhibitors. So we have 2 drugs that are approved for IDH1 and IDH2 mutations. And those happen in 20% of patients. Those are approved in the refractory relapse setting, but also there are trials that are combining them with 7+3. However, this is not yet shown to improve outcomes, so it's not a standard practice to combine it in outside of clinical trials. And then there's what we like to call vitamin V or venetoclax, because it's being combined with everything almost now in hematologic malignancies. This has been a major game changer in AML, where adding venetoclax to hypomethylating agents, specifically with azacitidine, has been shown to improve the overall survival in older unfit patients with AML. The median survival with the combo was 15 months compared to 9 months with azacitidine alone.
What about Mylotarg, Amer?
So Mylotarg is actually one of the very interesting stories. And again, you probably have had it back in the day when you were in fellowship, because it was approved some time ago, and then it was withdrawn from the market. I think it was withdrawn in 2000. I think it was approved in 2000, was withdrawn in 2010, and then it was reintroduced in the year 2017. It had a very interesting story of development that probably don't have the time to talk about today, but it's an antibody drug conjugate. So it's I tell patients, it's like a drone. You are delivering the chemotherapy component, the calcium by linking it to a CD33 targeting antibody. So most of the myeloid cells have CD33, and it's generally restricted to the myeloid bone marrow environment, so it doesn't cause a lot of toxicity, although it does in some patients can cause liver issues like VOD. It's a drug that's actually approved in combination with also 7+3. So I was actually on service 2 weeks ago, and I just gave a patient 7+3 with gemtuzumab. It has been shown in patients with core binding factor leukemia to improve survival when you combine it with 7+3 over 7+3 by itself. So that's approved, but also it's used as a monotherapy in older patients who are unfit. But the survival is not that great, so most people will not use it as monotherapy. They would use azacitidine with venetoclax instead, and also for relapsed refractory patients as monotherapy.
So my question to you then, we talked about, and I know we don't have a lot of time to cover everything. We talked a lot about the induction therapy, all of these. Is your goal of acute myeloid leukemia always after induction that you are going to take these patients to an allogeneic bone marrow transplant? Or are there patients that you think you can spare allogeneic transplant? Because we all know after induction for AML, 100% of patients will relapse unless you do something after they achieve a remission. So we don't have time to go over all types of consolidation, but I think transplant is the one that always comes to mind. So tell me, when do you decide you're going to do transplant versus not?
Yeah, and that's again a very good question, because you're right. I mean, with AML, historically, induction can lead to remission in many patients, but if you don't consolidate it further, the leukemia will come back. Typically, patients who have core binding factor leukemia or favorable type of AML, so 821 translocation in version 16, and patients who have a double CEPPA mutation or Mpm1 positive disease without FLT3 or other bad genetic markers, those patients generally you can avoid a bone marrow transplant if you give them in consolidation, multiple rounds of consolidation, which in the US typically is high-dose cytarabine. However, some patients still relapse, and if a patient, of course, has relapsed leukemia, the only way to try to have any sustained survival would be with a bone marrow transplant. There are other patients who you need to go to transplant, from the get-go, such as those who have complex karyotype. In the intermediate risk, it depends on the specifics of the patients. Do they have a good donor or not? But also we started to include MRD, measurable residual disease assessment. So it's not only achieving remission, how deep is the remission? And there are a lot of nuances to this, and whether you use a genetic assay or do you use flow cytometry, what is the best time to look for it? So it's an area that continues to evolve. But the short answer to your question is that, yeah, there are patients who you can cure without a bone marrow transplant.
And these are the ones that you said, the core binding factor leukemia ones.
Correct.
Where you can try to do that. The rest you do. Anything earth-shattering about acute myeloid leukemia at ASH? I think you alluded to a couple of things. Anything else at ASH that came across your radar?
Yeah, no, I think there are actually 2 or 3 presentations that I think are going to have important consequences. One of them was a randomized phase 3 trial. We discussed that azacitidine with venetoclax has become the standard of care for older unfit patients with AML as a frontline treatment. So one trial was presented in ASH that looked at adding an IDH1 inhibitor called ivosidenib to azacitidine compared to azacitidine alone. And that trial actually has met its primary endpoint. There was an improvement in the overall survival. The primary endpoint was event-free survival, but the overall survival was also improved, 24 months versus 7 months. So the main 2 issues with this approach clearly is that the IDH1 mutation is not that common in AML. It's only 5 to 10% at most of patients with AML will have IDH1 mutation. While venetoclax, you don't need any particular alteration. You could use it in anybody. So it's not targeted to the mutation. The second approach is that this trial tested azacitidine with ivosidenib against azacitidine, while the standard of care clearly is azacitidine with venetoclax. So it's an inferior comparator, which I'm sure, I've been following your podcast, and I know you discussed that multiple times with some of my colleagues. I think there are different reasons why this approach was used when the standard of care somewhat changes in the middle of the trial, and some of these trials accrue outside the US mostly. So I think what we have right now is two regimens that are clearly better than HMA monotherapy, but the real trial that we need right now is azacitidine with venetoclax versus azacitidine with the ivosidenib for patients who have the IDH1 mutation. Another important trial that was negative is actually adding to azacitidine, adding the FLT3 inhibitor, so gilteritinib. So there was a randomized trial called the LeSwing trial, and this trial compared adding azacitidine with gilteritinib to azacitidine alone, and in contrast to the other trial,
this was a frontline, this gilteritinib, which...
Yeah, this was in the frontline setting. So gilteritinib is approved right now in the relapse refractory setting, not in the frontline setting. So this trial looked at adding it to azacitidine compared to azacitidine alone. This trial was negative. So basically there was no improvement, and this trial was actually terminated early based on lack of futility, basically, lack that the combination is going to lead to better outcome. But there was actually a lot of debate in ASH about the design of the trial, the endpoint, whether some segments of patients, for example, patients who have high variable allele frequency or high mutation burden of the ITD FLT3 mutation might benefit. So I don't think the door is completely closed on the FLT3 approach in the frontline management of older patients. However, this particular approach is not likely to be it. And then you have a large number of trials that added something on top of azacitidine with venetoclax. So as you know, azaven is the standard of care. So now we are going into this triplet approach, and I think there are two implications for that. One of them is that the division of our classical approach of intensive chemo candidate versus non-intensive chemo candidate, which is always the other debate that we always had, in addition to which anthracycline to use, that is also starting to blur a little bit. So we are giving treatments more and more to patients who potentially could get intensive chemo. But we are realizing some of those patients are probably not best served by giving them intensive chemo, even if they can get it physically. So those would be the younger 60-year-old patients who have complex and bad cytogenetics. So it might not be a bad idea to kind of consider some of those approaches rather than intensive chemo in those patients. And I think the other approach that we are getting into, which is very exciting for us, is that there are oral versions of hypomethylating agents, and that's opening the door for double oral therapy, which I would argue would probably be completely something we cannot imagine 5 years ago, is that you can give 2 pills to an AML patient, like oral HMA with venetoclax, and you can get them into a complete remission. We always like to tell everybody that oral chemo does not mean it's not chemo, or it's oral. It still can be toxic. You still have to monitor the patient. It's still an AML. But I think that prospect is very intriguing to all of us who treat these patients.
Absolutely. Amer, this was great. I can't believe we covered so much ground actually in the past hour about MDS and AML. You're the, as my guest, is there anything I should have asked you about in terms of AML and MDS that is really important to share with listeners I may have overlooked?
No, I think you covered things quite well. I do think that things about how treatment is shifting to be more personalized in AML is very interesting, because we still have, it's very difficult to keep up with all the new developments in any cancer really these days. So I do encourage your listeners to always consult or call their colleagues who do these type of diseases, because there's always new interesting trials, there's always new approaches, and continue to enroll patients for MDS trials as well, because MDS is few years behind AML all the time. So I'm hoping for an explosion of new drugs over the next 5 years, similar to what happened with AML.
Where is your next trip?
Well, I'm hoping it's gonna be to Jordan to see my family, but you never know with the COVID situation. But
Well,
fingers crossed.
by the time this airs, there will be things will be hopefully COVID is going to be endemic, and we do what we can, and so I hope you get to see your family very soon.